everyone. Today we are going to learn the abnormal breath sound. So my name is Gao Yuan from Shengjing Hospital of China Medical University, and welcome to have these lessons. In these lessons, we will have 3 parts. The first one is abnormal vascular breath sound, and second is abnormal bronchial breath sound, and the second is the abnormal bronchiovascular breath sound. So we have abnormal lung sound. Some have increased lung sound and decreased lung sound. So there are different reasons for the increase, like diffuse, symmetrical increase, like physiologic in ventilations, like exercise, hypoxemia, excitement, and pathologic in ventilation, like fevers, severe anemia, and also some localized increase of the lung sound, like lung consolidations, like pneumonia, like pulmonary mass, and also some decreased lung sound, like pleural effusions, and in emphysema and diaphragmatic hernias. For the next part, we will learn the reasons for the abnormal vascular breath sound. The first one is decreased or absent. There are many reasons for we didn't hear the lung sound, or the lung sound is decreased. So the first one is like a restricted movement of the thorax, like if the patient have fractures and they have chest pains, they cannot breathe. So they have like restrictions, or some reason of ossification of rib cartilage or rib resections. For this part, like if they have a trauma, they have chest pain, they need restrict movement of thorax. So when you do the auscultation, it's decreased. And second reason is respiratory muscle disease, like some myasthenia, diaphragmatic paralysis, or diaphragmatic muscular spasms, like some muscle disease. If they have the respiratory muscles, you cannot breathe to like so big and so long. The sound is decreased. And the third reason is for the bronchial obstructions, and it's very common in the clinic in our like respiratory disease, like chronic bronchitis, bronchial strictures, like COPD, and some like asthma patients, they have spasm, they have the bronchial strictures, they have like decreased breath sound. And the fourth one is oppressive under expansion of the lungs. If they have pleural effusions or pneumothorax, so the lung cannot expand so much. So the lung sound, you do the auscultation, so they have a lower, like they have decrease of sound. And even if they are a big amount of pleural effusion, you cannot hear breath sound. And the fourth reason is abdominal disorders, like the patient, they have a massive ascites or huge tumor in the abdomen, so they cannot breathe with their diaphragm, so they have like a lower or decreased breath sound. And also the second is increased alveolar breath sound. It can be accentuated on both sides, like exaggerate respiratory movement or ventilations. And the first one, like body oxygen demand increase, like if you do exercise, you need more oxygen, so you breathe more deep, more quickly. So this you do the auscultation, the breath sound is increased. Like sometimes you have fever or high metabolism rate, Also, you need more oxygen and increase, so you breathe more deeply, more quickly. The sound is also increased. The second one is anoxia stimulates respiratory centers. Like if the patient have anemia, they have low amount of hemoglobins, they need more oxygen to breathe. The sound is also increased. The third one is blood acidity increase, like the patient have acidosis, like they have a disease, like we learned the Kussmaul respiratory Kussmaul. So they have more acidosis, so they need to get more carbon dioxide out of the patient's lungs. They need more deep and quick inspirations. So the sound also, they have increased alveolar breath sound. And also, this is reason for the both part. They have unilateral accentuated, like unilateral thoracic pulmonary disease. They have diminished alveolar breath sound on the involved side and compensatory accentuated breath sound on the normal side. If the patient have a large amount of pleural effusion, if the patient have lung cancer, they have a huge amount of pleural effusions. This side, there is no breath sound, but the other side, they need to compensate for the respiratories. So the other part is like compensatory accentuated breath sound. So the third one, we have elongated expiration breath sound. So the causes usually is uncompleted obstructions or partial compression, or sometimes spasm or stricture of the lower respiratory, or decreased alveolar elasticities. Like the common is like bronchitis, asthma, emphysema. Like most common, we have COPD patients, asthma. When you do the auscultation, you have an elongated expiratory breath sound. Sometimes you hear the wheezings. So normally, elongated expiration breath sound is because of the stricture of the lower respiratory bronchioles. And the fourth is interrupted breath sound, also called cogwheel breath sound. If the bronchiole, or if the patient have segmental pulmonary inflammation or bronchial structures, like if the patient have TB, have pneumonias, they have like segmental pulmonary inflammations, you will hear the interrupted breath sound or cogwheel breath sound. And the fifth is the hoarse breath sound, the smoothlessness or stricture produced by mild bronchial membranous edema or inflammations. So for this one, it's usually seen in the early stages of bronchitis of pneumonias. And also, in the upper part, we know the abnormal increase and decrease of vascular sound. And also in our daily work or clinic, we hear the patient, we can hear abnormal bronchial breath sound. So for the bronchial sound, it also called tubular breath sound. It usually heard at a location a certain location. But when the bronchial breath sound is heard at a location where vascular breath sound should be heard is abnormal. So this is wrong. You hear the inspiration and expiration is equal, and it usually indicates there is consolidation of lung tissues or big cavities in the lungs or presses atelectasias. So if you hear in the vascular sound positions, you hear bronchial breath sound, it's abnormal. maybe indicate you need to have the patient have a chest X-rays, have a CT scans, or have the blood routine and CRP to confirm if there is something wrong in the lungs. And the third one is abnormal bronchoalveolar breath sound. So the area where only normal alveolar breath sound is heard is because the consolidated part is smaller and mixed with normal air-contained pulmonary tissues. The consolidated part is deep and covered by normal lung tissues. So the causes is bronchitis, TB, and early stages of pneumonias. So this is why we first learned the normal breath sound. I have tell you there is full breath sound. In certain position, you hear certain breath sound. And for the abnormal breath sound, if there is like bronchial breath sound, bronchoalveolar breath sound, in vascular sound, there should be something wrong. So this is for today's lessons. Thank you.